right, we're going to quickly pivot from antibiotic stewardship to antibiotic resistance and trends. Let me just mention that Medmine has provided for everybody, and I see several already, the state antibiotogram that's available outside. So be sure you get one if you haven't gotten one. Our speaker that's going to address us on antimicrobial resistance is Dr. Felicia Matthews. She has a doctorate in pharmacy from Auburn, has a significant VA clinical experience after doing a residency in geriatrics, and is a senior consultant currently with Medmine. So please help me welcome Dr. Felicia Matthews.
All right, so indulge me because I'm a pharmacist and I'm slightly nerdy when it comes to drugs, so I'll get really excited about some of these and then just bear with me a little bit.
Turn your mic.
I took it off. I did break it. Can you hear me now? I think I'm gonna have to hold it. Okay, so these are my disclosures. And so we're gonna talk about antibiotic resistance and the emerging threats that they cause. We'll look at some new drugs to combat that emerging resistance. I'll give you an update, just a really quick update on some of the regulations for antimicrobial stewardship. We'll look at our statewide antibiogram, and then also look at some of the antibiotic trends across the state. So these are the numbers that I want you to remember when we begin to talk about antimicrobial resistance. There are over 2 million illnesses in the United States that deal with antimicrobial resistance, and that leads to 23,000 deaths. 500,000 of those illnesses are coming from Clostridium difficile. Now, what we really do to actually need to treat that particular disease state is not resistance to antibiotics, but it is driven by the way we use antibiotics. It's driven by antibiotic resistance, and it leads to 15,000 deaths a year. That's over half of the deaths that we see yearly from this particular I guess illness that we've called, because it's really an illness that we've caused. And that's $20 billion in direct healthcare costs. So think about what you're asking for, what FTEs you need. We're spending them in how we're using antibiotics. And that's $35 billion in lost productivity. So I'd be remiss if we just didn't go back and say, what's actually causing this resistance? So you have these germs that are there, and most of them can be treated by the antibiotics that we have. But there's a couple that are resistant. And we know that our antibiotics are not specific. It doesn't say, oh, hey, you have these like 5 germs here that are overacting. I'm gonna wipe those out. And the broader spectrum of antibiotics that we give, we wipe everything out, except for the ones they're resistant to. They get together, they party, they pass off their resistance, and now you have all of these resistant germs that are left without antibiotics to actually treat them. So the CDC came out with a way to define these different threats, and I'm gonna talk about 2 of them, the urgent and the serious, and specifically we're gonna talk about C. diff, MRSA, and ESBLs. So I've already gone over the numbers with C. diff. What I didn't tell you is that originally when this came out in 2013, the number of infections per year has doubled. And we've increased the deaths by 1,000. What has that done to excess healthcare costs? Almost 5 times the cost. So it's gone from $1 billion to $4.8 billion in excess costs. And 80% of these infections are patients that are 65 and over. But it's not in the hospital. It's mostly in a nursing home in the community. Only about 24% of the C. diff infections that we see are actually in the hospital. So they've done some additional work on this in the CDC. And if we decrease our use of antimicrobials by 35%, we would be able to see a 25% reduction in Clostridium difficile. There have been other studies that's been done abroad in Canada and Europe that they saw a reduction up to 65% with stewardship. 65%. So new guidelines came out this year to address Clostridium difficile. I just want to talk about 3 really important areas: prevention and control, testing and treatment. No longer do they want us using metronidazole for the first case of Clostridium difficile. We should be using a 10-day course of vancomycin or a 10-day course of fidaxomicin. Second course, or second occurrence, 10-day course of vancomycin with several weeks of vancomycin pulse therapy, or you can then use a 10-day course of fidaxomicin. Third case, same patient. They want you to consider a microbiota transplant. So this is getting serious. Now, I heard that kefir can do the same thing and it's $4 at the grocery store. I can't say anything about that for sure. I was at a presentation, that's what the guy recommended. But they still have not said anything specifically about using probiotics in this patient and whether or not it's beneficial. For prevention and control, just what the previous speaker just talked about, they want to make sure that we're limiting the use of antibiotics that can increase the risk of C. diff. Fluoroquinolones, clindamycin, broad-spectrum cephalosporin, so your third and fourth generations. You're going to have to use these, but they definitely want us to limit them. And they also want you to monitor your durations. The patient needs a 7-day course of antibiotics. They're in the hospital for 4 days. They get 4 days in the hospital and a prescription for 7 days when they go home. Make sure that if they only need 3, they only need 3. And they feel better on day 3. So what do? I don't need this. I'm not going to take it. Please encourage your patients that I know you feel better. Please complete your course. Because when they don't, that increases resistance because you almost killed them. So now you just made them strong and you fed them with stuff. And that's not what you want to do with the germs. For testing, and I thought this was a little different. I'm not sure, I don't do a lot with testing. But they only wanted you to test patients that had a risk. So some type of risk factor for C. diff. And then they had to have at least 3 loose stools within a 24-hour period. So is that consistent? Pretty much what's going on. And so these are all new guidelines that came out, I believe around February for IDSA. So you guys can go to their website and pull it and get additional information. Now when we look at ESBLs producing Enterobacter ACA, those numbers look much different. You're like, why are we even talking about this? You're talking about 500,000, this is 26,000 is nothing with this. This is gonna be your Klebsiella. This is going to be your E. coli. This is gonna be your Pseudomonas. These are going to be the organisms that we're only gonna have one drug class to treat them with. That's gonna be our carbapenems. The more we use our carbapenems, the more we increase carbapenem-resistant Enterobacter ACA. And guess what we have to treat that with? Absolutely. Have nothing. MRSA. So not quite as bad as C. diff. And it's done a lot better. I mean, we have done a lot better with it, and it's really because of the work that you all do when patients are admitted to the hospital, when they are transferring, making sure we're swabbing those patients, making sure we're pulling those patients out. That work has been wonderful. But the thing I want you to take away is that as far as healthcare associated infections, it's still the highest. So even though we've done good work, we still have more work. So now after I've scared you about all these bugs that we don't have anything to treat with, to talk to you about a few medications that are coming to market that we can actually use for these. So there's about 4 new drugs that have come to market for our gram-positive. So dalbapacin is one that came out, has a really high affinity for MRSA, higher than all the current drugs we have in the market. Half-life is about 170 to 210 hours. That's 1 to 2 doses, all you need of this. Now, the 1 dose, they said wasn't quite as good as the 2 doses, so would recommend 2 doses, and it's over a 30-minute infusion. When we look at ortarvicin, we actually pick up VRE coverage with this one. Its half-life is 200 to 300 hours, one-time dosing. So for those patients that they really don't have, you really don't want to give them a PICC line, you really don't want to put them in the hospital, you might be able to identify what they had when they came in, they're right there in the ED. You could stop it right there. It stays in the community. it doesn't go and spread to your hospital to your other patients. Now, Tedazolid, think of it like linezolid on steroids. More potent. It's actually going to be able to be dosed a little lower, about a 5-day time frame that you need it. But the good thing about this one is that the side effects that you have with linezolid, you don't have it with this one. So if you have a patient that needs to be on a serotonin-containing agent, they can be on it with this one. If we have a lot of issues that I've seen whenever I've used it with the patient, if they're on it for over 10 days, they're gonna have thrombocytopenia. You don't really have that issue with this one. And go back, because orotarvicin, the big thing with it is that you can't use it with heparin. So within 5 days, you can't use it. That is not, it does not cross over to lower molecular weight heparins, but if you had a patient on heparin, you can't use that particular antibiotic. For delafloxacin, you're gonna lose VRE, covers the MRSA, but it's a fluoroquinolone, it's broad spectrum. Really good MRSA coverage, but it also has really good gram-negative coverage. And because of that polymicrobial coverage, you're gonna wipe everything out and you're gonna increase your risk of C. diff. So it's kind of one that you just kind of keep in your back pocket. If they've got dual things going on, then that's the one you wanna use. But if it's specifically MRSA, I'd recommend one of the first 3. So these are some things in the pipeline. I'm not gonna go through all of these, but I'm just gonna go and touch on a few that I think are really important. So lefimulin is one that gets MRSA, VRE, gets atypicals. It gives you an IV and a PO formulation. Because it's a novel class, there's no cross resistance. So you don't have to worry about if they've been on another class of medication, can they take this one? They're gonna be okay with that one. The zavofloxacin, think of it as Moxie. We rarely use Moxie. Moxie is just for everything up. That's how I like to think about it. Moxie only gets stuff from up above. So all of these are in phase 3. Not really sure when they're gonna. I try to check to see if any of them come to market yet, and they hadn't before the presentation, but that's just one that you'd wanna kind of put in your back pocket. If it does come out, probably could use Moxie first instead of using it. Fludizic acid. This one you're gonna pick up bone and joint infection. So we'll have something more than vancomycin to treat those things and keeping the patient in the hospital or keeping them on 6 months of therapy or 6 weeks of therapy. This is already available in Europe and Canada, and it has been for decades. No cross resistance with other classes. So lithromycin, I just think it's important to mention that. It may not ever come to market, but now that we have more resistant gonorrhea to now macrolides, this is potentially another drug class that can help with that. So the gram negatives are gonna be what's more important here, because like we talked about earlier, they don't have anything left to treat once they're carbapenem resistance. So ceftolozine tazobactam is gonna give you coverage for complicated UTIs and intra-abdominal infections, and it has a really good Pseudomonas coverage. It even covers Pseudomonas that is carbapenem resistant. So when you think about these drugs, and think about it this way, we know that it's new, so it's more expensive. But if I was to give a carbapenem that may be cheaper, and it doesn't actually get everything I need, and now I have a carbapenem resistant organism, and I'm going to have to use a minimum of 3 or 4 drugs to try and begin to treat that patient. You can use one drug, it might be more expensive, but you won't build up additional resistance. So all of these drugs came to market to actually help us decrease that carbapenem resistance. For the ceftazobactam, you're gonna pick up treating CRE for all other gram-negative organisms. So for the first one, you just had coverage for carbapenem-resistant Pseudomonas. This one, you're gonna get other extended spectrum beta-lactamases that we talked about earlier. You're gonna get CRE for other things, and you also get good Pseudomonas coverage. For the meropenem varibactam, you lose your Pseudomonas coverage. Treat the SBLs, you get the CRE, and the varibactam, sort of like the imipenem, is gonna increase your risk of seizures. So if you have a patient that's on valproic acid, you're gonna actually have to increase that dose, and it also increases your risk of thrombocytopenia. With all of these, what I want you to just remember, because it will be very important later on, is that they don't cover Acinetobacter, nor do they cover Centrotrophomonas. Nothing new. So for this one, Cefiderocol is the coolest drug that, if they brought it to market, that could ever be there. Because what it does is it binds to iron. So the organism doesn't know what it is. And so it's like a Trojan horse, goes into the cell wall, disrupts the cell wall synthesis. And the organism is like, what? What happened to me? How did you get rid of me? So I'm not gonna talk about the other two, but that one, to me, that one's totally cool. That's cool. So quickly on regulations, we talked about Joint Commission, right? We must always talk about Joint Commission. And because they had their antimicrobial stewardship standard in place that was effective in 2017, everybody wants to know, what are you looking for? What do I have to do? As the presenter just said, oh my God, do I have to start my 48-hour timeout right now? And you don't. What they want to make sure is that you have a policy in place. Like everything else, your policy, they don't have to like your policy, but you gotta have a policy to say what you're actually going to be doing. They can tell you we think you should improve it, but you must have a policy in place. The next thing is that for the data that you're collecting, they don't care what that data is. 48-hour timeout or not, they do not care. What they care about is whether or not you're able to show improvement with what data you are collecting. So what's happening in your facility? What's important to your hospital? It may not be important to the next hospital. So as long as you're collecting data and you're able to show this will actually help decrease this in my hospital, and it did, and this is how we did that, they're gonna be good with that. The next thing we talked about education. So he was talking about education with the patient, you still have to educate your people in your hospital. And if you just talk to your providers about an antibiogram, they consider that to be written education. So I've had some pharmacists say, yeah, we put it on our antimicrobial stewardship meeting every month. Every time we have it, we put it on there, we go over it, and they consider that to be fine. Now the one thing that they would actually probably give you a requirement for improvement on is if you do not have a physician on that committee. They are not going back to check and see whether or not are they ID trained, are your pharmacists ID trained, have they had a training course that they've gone through. They want to know that everybody that is supposed to be at the table is at the table. So quickly for CMS, long-term care, that was approved and it must be implemented by 2019, I believe. What they want is to make sure that there's an infection preventionist designated at each facility. If a patient is on an antibiotic, they must be reviewed by a pharmacist doing the monthly pharmacy review. For the Medicare Beneficiary Quality Improvement Project, this is for your rural access hospitals. That one gets a longer time out, about 2021. They already have about 200 hospitals that are signed up, and that's to make sure that they actually have an antimicrobial stewardship program. They also want to make sure that they are submitting their annual survey that he just talked about to NHSN. And I think they just had some things that came out that Leapfrog, that if you are a member of Leapfrog, you can actually give them access to your antimicrobial use and resistance information that's inside of NHSN. So that's an option for you now. For conditional participation for critical access hospitals, the government says it's still important, yet they haven't voted on it yet. That's nothing new. But I don't think that that's going to change. They really are concerned about what we're doing as far as resistance is concerned. And I think they're trying to just kind of figure out how to best implement it. Because as we talked about last year, that's going to be pretty expensive. So now to our antibiogram. We took isolates from 56 hospitals in Alabama from all of 2017. We looked at one isolate per 365-day period. Duplicates were removed, and significantly different susceptibility results are considered to be unique or non-duplicate. For for the purposes of this presentation, community is considered to be collected from the outpatient or inpatient within the first 3 days of an admission, with no admission within the past 14 days. So hospital is on or after that 3-day or within 14 days of a discharge. So we're really going to focus on just a few of the organisms that's really important to the hospital. And if we look at Enterococcus, we can see that we've had a decrease in the number of isolates, and that's for our non-urine. Now, the amount, for the ones that are really resistant, our Enterococcus faecium, it's just changed a little bit, 33 to 31% from last year. So that's still flat. And when we look at that, the resistance pattern hasn't changed at all. We still have 80% resistance to vancomycin, 6% resistance to linezolid. So we still are able to really treat this very well with the antibiotics that we currently have. And we have a few new drugs to market that can help with it as well. And we can still, I always think, Enterococcus faecalis, treated with a list of things. Still very, very susceptible to vancomycin. For MRSA non-urine, like I said, we've really made great strides. We're at 58%, still a little bit higher than everybody else in the country. In the Southeast, we tend to have more cases of MRSA, and they really think that that has to do with the fact of the amount of diabetic patients that we have in the South that drive up those MRSA infections. The difference that we actually see is between community and hospital. So about 2013, they seem to be trending right along there together, and then there's a separation. And so the values are not listed here, but the hospital again is at 58% and the community is at 53%. So there's about a 5% difference in what we're seeing as far as MRSA in the hospital and the community. For Klebsiella pneumoniae, we're looking at resistance to meropenem. So we started looking at meropenem and imipenem because more hospitals are using that now. And although we've had a larger number of isolates, we still have a smaller number that are resistant. What we are seeing is that we have a larger resistant pattern now in the community than we do in the hospital. So again, we can use some stuff to keep the people out of the hospital from continuing to transport these resistant factors. That's really going to help. Now, this is what I was talking about earlier, Acinetobacter. This is different from the other slides because we're looking at isolates that are susceptible, not resistant. And we had done so well until this year. So we were up to having a 70% susceptibility, and now we're down to having a 53% susceptibility. That's really, that's significant because with this particular organism, it is hard to treat, high risk of morbidity and mortality. You're going to have to use more than one drug. And if we are losing susceptibility to the largest antibiotic that we have, and there's nothing left, and nothing that they're making, and nothing in the pipeline in the market to actually treat this, this is something that could cause us a lot of issues. So nationally, they have the resistance of Acinetobacter somewhere about 78 to 74%. They could be doing some different things with HAIs. They may not be doing nursing home in there. The reason why they're a little bit higher than what we are, but we're really good at susceptibility compared nationally, but 17% drop, it's not great. So Pseudomonas, I'm gonna go through several different classes of antibiotics with it. We still have really good susceptibility to our Piptazo and cefepime, so that's in the 80%. Our H-Tranum has decreased some. So we've gone from 66 to 60%. Usually we're using that for treating our patients that have a penicillin allergy. So again, that might be one of the things where the speaker talked about earlier. Are we looking at desensitization? Does the patient really, can they really not take a beta-lactam? Should we not check on that? None of the values are here for this, but amikacin, gentamicin, tobramycin, these are all our aminoglycosides, and they look great for everything because we really can't use them for a lot of people because of all the nephrotoxicity that they cause. So the amikacin and tobramycin, which are right up at the top, they're actually 91 and 90% susceptible. And gentamicin has improved and it's 80%, and it's improved over the past 5 years. Now for meropenem, it's a little bit different. So the imipenem and meropenem, they've increased from what they've been before, but it's still 70%. And if I told you I was going to treat you with an antibiotic that had a 70% chance of treating what you have, you'd probably look at me and say, you ain't got anything else to treat me with. So it's still not something that we really want to use to treat this. We do have new drugs to market that can help with this, but we still just want to keep an eye on it. And same thing for our fluoroquinolones. It's improved. It's improved significantly. Again, if I told you I'm treating with something 70%, you'd probably ask for something different. So this is still not one of those things that we want to use empirically when we're treating these patients. So just in summary, Enterococcus faecium has remained pretty much flat. We still have really good drugs to treat that with. MRSA in the hospital, we haven't changed geographically. We're going to have more MRSA that's going to be around the country, so we just have to make sure that we monitor those patients, and if we can give them some things or use some things that keep them out of our hospital, that's going to be a good thing. For our Klebsiella, we are seeing a change between the community and the healthcare system. So we're having more resistant strands in healthcare. Acinetobacter, huge drop in susceptibility. That's something we're really going to have to monitor, and it's more than likely that we need to monitor how we're using carbapenems for other infections to make sure that we're not losing it for this particular organism. And then our Pseudomonas nightmare in the hospital, resistance to the carbapenems and the fluoroquinolones are still flat. So nationally, what is Alabama doing compared to other Medmine hospitals across the country? We're kind of right there where they are as far as teaching hospitals about how we're using our antibiotics, so nothing that's drastically different from everywhere else. Our carbapenem utilization is actually lower, so that's good, but we still have some issues with that. Our piperacillin tazobactam is still really high, and I thought that that was kind of funny since we have a huge shortage of it going on right now. But we still need to make sure that we are de-escalating that therapy when it's appropriate. Fluoroquinolones had gotten better. Seems like we had been trending pretty much what other hospitals were nationally or regionally in our area that were teaching, non-teaching. Started to go up a little bit fourth quarter, so we still need to make sure that we're keeping a good handle on what's going on with the fluoroquinolones, because I think we hit it really hard, and then you're like, oh, okay, I'm good, I don't have to worry about it anymore. And then it starts to resurge again, and people start to use it, so we just have to monitor that. Our third and fourth generation cephalosporins, again, that was trending right along with other teaching, non-teaching nationally, started to go up a little bit third and fourth quarter, so that's another one to watch. And our use of vancomycin, linezolid, daptomycin, tigecycline, still right in line with everybody else, a slight increase fourth quarter, but nothing really significant. Now the last one I'm going to talk about are proton pump inhibitors, because they are the only non-antibiotic that increases our risk of C. diff. And our utilization is really high. And that was one thing that they actually talked about in the guidelines, is that we really need to make sure that if the patient was put on it for stress prophylaxis, that we stop it. Even if they have a GI condition that says you should be on it, don't just leave them on there for forever. Reassess that patient. See whether or not they need it. Thank you for your time and attention, and I will take any questions that you may have.